So, Max, thank you for inviting me to this very interesting conference, Seeking Alzheimer's Solutions. In seeking solutions, I think it's really important, as much as possible, to understand what we know about two classes of information. The causes, to what degree we know them, and the consequences of the disease. Among the consequences that are well defined are memory loss. This is the paradigmatic symptom of Alzheimer's disease. Pure recent memory loss is what characterizes it initially. No other dementia has that characteristic. And the loss of synapses. In multiple autopsy studies, beginning with Bob Terry and others, it's been seen that a major consequence is the loss of the wiring in the brain. You can't expect a computer to work, nor can you expect the brain to work if the wiring is degraded or gone. In addition, you have as consequences the accumulation of amyloid plaque and tau. And those four consequences defined by the Neurologic Institute, my home institute at NIH, what Alzheimer's disease is. That's a fact. And I urge us in our discussions today to stay with the facts and less with the claims or the potential possibilities of the facts. The facts ultimately will lead us to the therapeutics and the diagnostics. Alzheimer's disease, by definition, has as a gold standard loss of memory, dementia in life, and amyloid plaques and tau at autopsy, and the loss of synapses, which has not yet been accepted as a pathologic criterion, but which is a hallmark, and which is the only one that's closely correlated. We can go to the next slide if we can. And the next one. Which is the only parameter pathologically that's closely correlated with cognitive deficits or memory loss. That's the loss of the synapses. And that's been shown with multiple studies. What do we know about the causes so far, in addition to the multiple factors such as high blood pressure, diabetes, age dependence, genetics, etc., inflammation? We know that oligomers, the pre-plaque soluble forms of amyloid plaques, oligomers, are synaptotoxic. We also know that, and we know that in the Alzheimer brain, there's a deficit of PKC epsilon, which is a master coordinator of some of the pathways you've heard reference to, but the master coordinator of synaptic growth factors, apoptosis, and anti-amyloid and anti-tau. There's a deficit of PKC epsilon in the human brain. And there is a deficit right along with it of BDNF in the human brain of Alzheimer patients. We've, of course, confirmed that, as with many others, but we've confirmed it in collaboration with the Harvard Brain Bank. So our approach is to use a multimodal approach that actually has the potential of addressing both the causes and the consequences of this disease. And the population that we chose to go after, no other drug company in the world today is treating, because it's proven impossible. We're looking at advanced, serious Alzheimer patients, patients who have an MMSE, a mean of about 10 or less, and patients who have lost a considerable amount of the wiring and the neurons in the brain. And we have seen, and I'm going to summarize this in this brief outline, we have seen going from bench to bedside, going from basically very basic biochemical experiments in vitro, then in vivo, and then through phase 1, compassionate use, phase 2, exploratory, and now in our latest phase 2, confirmatory. In all of these trials, we've seen a progression of benefit that suggests that going after these deficits of PKC epsilon and BDNF, which actually indirectly regulate the synaptotoxic A-beta oligomers pre-plaque, as well as inflammation that Dr. Perry has talked about, it actually has these multimodal efficacies, and going after that shows something that we haven't seen before. What haven't we seen? We haven't seen a drug that actually improves these patients. We're not talking about slowing of decline. We're talking about reversing the decline and getting these patients better. We believe in this advanced population, these patients are showing improvement that has never been seen before. Is it definitive? Is it final? Is it ready to go on the market? No, but we believe we're on that path. And the signals that we've seen, and I'm going to share with you, suggest that we're not only treating symptomatically, but we're actually rebuilding the synaptic networks. And that sounds a little bit futuristic. It's a regenerative approach, but I believe, based on our preclinical data, which is very extensive, and based on our clinical data, that that's likely to be what we're doing. We're actually regenerating, we're preventing the neuronal death, and we're regenerating the synaptic networks. Some of the talks you heard are touching on this. In my opinion, this is what will be necessary if we're ever going to really treat this disease. We don't feel at Neurotrope in any way confined to just treating severe patients. We can even treat the epigenetic factors that you heard about. We can treat the early and the moderate stage, but we chose a very challenging population to see if we could benefit them. And one of the reasons we chose that is because we did compassionate use trial patients first, and we saw remarkable benefits. Patients who couldn't swallow had swallowing restored. Patients who couldn't speak started to speak. Patients who couldn't walk, who were hallucinating all the time, started to engage in complex physical activity. And that's really what we're about. That's what we're trying to do. And it happens that other university academic centers have been using our therapy model to treat other diseases like potentially multiple sclerosis, Parkinson's disease, Fragile X mental retardation. All of those preclinical studies have been done and shown remarkable benefits along the same kinds of lines we've seen both preclinically and clinically. And I'm just going to go through this with a few slides. As I mentioned, we're focused on the synapses, but as you will find out that when you put toxic soluble A to beta oligomers on neurons, first thing that goes is the synapses, then go the neurons. So you need to deal with apoptosis or death of the neurons. And it turns out that the PKC epsilon synaptic growth cascade and anti-apoptotic BCL2 cascade address both of these arms, both synaptic regrowth by mobilizing all the major synaptic growth factors, not just NGF, but BDN, FG, NGF, IGF, etc., all of them. And then we know the molecular pathway by which it does that. But it also prevents and interrupts the cascade for death. So it regenerates, it rejuvenates the neurons, and in addition regenerates the synaptic networks. But in addition, it also prevents the toxicity of the soluble A-beta oligomers. It prevents tau hyperphosphorylation and thus the neurofibrillary tangles. And it restores cognitive deficits. So if we can go to the next slide. These are facts, guys. And ladies. These are facts. This is one of many studies that have been done that show that the correlate of cognitive deficits, memory loss, paradigmatic, is not amyloid. It's the loss of the wiring in the brain. It's the synaptic loss. And these values were done by electron microscopy. They parallel exactly what we got when we did these with transgenic Alzheimer mice. And that's what happens early in the disease. Not amyloid, not tau, not the, in my opinion, misleading claim that you can recognize this disease 20 years in advance or that you can make the diagnosis 98%, none of which, in my opinion, has been substantiated. Because the only way you can substantiate it is with autopsies. That takes years. Fortunately, at the Rockefeller Institute, where I was the founding scientific director for neuroscience, we had the years, and at NIH, we took the years. With faith in God, you believe that you're going to be around for a little while, long enough to persist to see the benefits. And I was fortunate enough to have my faith answered. So, synaptic loss, next slide. These are our two primary actors to see pathologically: amyloid plaques and tau. These are the molecules, the bad actors, but these are not the only molecules. You heard about oxidative stress. PKC epsilon deals directly with oxidative stress as well as pathways around it and inflammation. PKC epsilon activated by the gift from the sea, as Max would say, Bryostatin, actually is very anti-inflammatory. In fact, In the first phase 1 trials done for cancer in 1,500 patients, one of the earliest demonstrations was that it is anti-inflammatory. That's why we think it works so well in multiple sclerosis, and that's why we think it's got another property that's important for Alzheimer's disease. Next slide. PKC epsilon regulates the synapse, not only its function, but also its structure and its formation. And we've traced each of these, including the PSD95, the anchoring protein. We've traced it stepwise in the formation of the synapse. So it's not by accident that if we're treating with Bryostatin, which activates PKC epsilon, that we can potentially regrow the synapses. Next slide. So these are the multiple efficacies. On the right-hand side, you see them, excuse me, both protective function and actually neuroreconstructive functions. This is part of the molecule that we're talking about. Next slide. And this is an example in culture using human neurons, looking at the synaptic networks, treating with toxic soluble A beta oligomers as a model. It's the same thing we do with transgenic mice, and then using Bryostatin to basically protect and regenerate the connections. Next slide. These are the clinical results of the last phase 2 trial. In the orange, you see a specific dose, which this exploratory trial revealed to us, and that's why we needed an exploratory trial, was totally safe, but it was very effective. Notice we're at 0. See the origin. We're now, in the absence of memantine, and there's a reason why you can't have memantine based on the neuropharmacology of how PKC epsilon regulates the glutamatergic receptor. In the absence of memantine, you see a steady improvement. And actually, look at the dashed fiduciary line. That's where the trial stopped giving drug. Notice that the patients are still improving. This is severe impairment battery, an accepted metric for advanced Alzheimer patients. Never seen before with any of these advanced Alzheimer patients. And what you see is improvement. Even 30 days later, after the drug has stopped, the patients are still improving, still showing benefit. The only way, in my opinion, the likely way that this could be working that long is it's rebuilding the networks. It's not just enhancing neurotransmitter. So this gives us the opportunity to do something that hasn't been done before. To treat the underlying disease, to treat the progression of the disease, not just to treat the symptoms of the disease. And that's what we're after. We want to treat the symptoms, but we also want to treat the progression. And these are 2 control groups. The blue are SIBO groups. The green are patients who had memantine addition. And you can see there's no doubt that there is an improvement. Next slide. And these are different clinical indications that we're going after, all of which have involved the loss of synapses, and in the cases of multiple sclerosis, the loss of the axonal sheath, and the oligodendrocytes that regulate the restoration of that sheath is via, guess what, synaptic growth factors. So that's why and it's also inflammatory. That's why we think we're getting such benefit in the models of multiple sclerosis. Next slide. Now we'll just pass that one. Pass that one. And we just talked about that. Next slide. Next slide. And these, if you look at the left and the right, on the right is what's called a trend analysis. In this case, a trend analysis is not talking about a statistical trend. It's talking about the degree to which the drug benefit is increasing or sustained as a function of the drug dose. Very few trials have ever shown this in any case, but in this case we saw with the right dose, which is the upper red-hand line, at the 0.001 level, a clear benefit of these patients, advanced patients, as a function of the dose. This gives us, in my opinion, a great deal of encouragement that we're going to see in the trial that's going to read out in the next few months a similar, perhaps even better result. Next slide. This is a cartoon of the NMDA receptor. PKC epsilon, activated by Bryostatin, regulates it at very numerous sites. By having memantine in there and blocking it, you actually block part of the effect, the efficacy of the drug. And so for this reason, we found virtually no effect when the memantine was there, and then the clear effect when memantine was gone. So in the current trial, we had no Namenda. I should say that one of the people who was on the team that founded Namenda and got it approved in 2003 is our CEO right now. So he was excited to be on a different path. I think we're just about finished. The last slide. Can I pass that? Yes. This is Fragile X. Another indication for which we have orphan drug status and for which we have a lot of preclinical data. And there too, the synapses are lost. And we could restore those completely. The Fragile X Foundation repeated our data in the last slide. This is a study at PNAS by the Hopkins group, headed by Saul Snyder. They use exactly our protocol, and we're now collaborating with them on a clinical trial for multiple sclerosis as well. Our hope then is to take a neuroregenerative approach to many diseases in which the wiring is lost, in which we hope to restore that wiring, as well as the cognitive capacities that wiring allows to happen. Thank you.